Hi everyone, thanks for joining this presentation on pediatric pharmacogenomics. The presentation is part of PPA's Core Competency series. My name is Lou Gorth, and I'm an assistant professor of pediatrics at the University of Colorado's Skaggs School of Pharmacy, and I'm also a clinical pharmacist at Children's Hospital Colorado, where I am lucky to get to use pharmacogenomics and precision medicine as a pretty regular part of my current practice. I think that precision medicine is really the future of pharmacy, and it's where we're headed in the next few decades. And so I'm excited that PPA chose this as an important talk as part of the core competency series. Before I get started, I want to note that I do not have any conflicts of interest related to the contents of this presentation, nor do I have any affiliations or involvement in organizations with financial interests related to the subject matter discussed in this presentation. At the end of this presentation, you should be able to describe the goals of precision medicine and utilization of pharmacogenomics. You should be able to identify some available resources for clinical pharmacogenomic guidance. We'll provide some examples of common pediatric pharmacological therapies for which pharmacogenomic assessment might guide decision making. And you'll also be able to interpret pharmacogenomic results to determine appropriate medication dose adjustments within an example patient case. So let's dive right in with the most important question of the day. Why do we even need to talk about pharmacogenomics? I think all of you have probably seen in practice that some patients respond differently to some medications. Starting in the bottom right of this graphic, there are some patients for whom medications pretty much seem like placebos. So they don't have any toxicity, which is great. There are no side effects, but there also may be no benefit. In some patients, we may see strong benefit, like in those in the yellow group on the bottom left, but those patients may also experience toxicity, and those side effects could be dose limiting. They could make the medication something that we're unable to use in those patients. They could just be something that's uncomfortable that the patient has to manage. But there's other patients who get all of those toxic effects, all of the adverse effects of the drug without seeing any benefit. And finally, in the top right is really the key group of patients that we're targeting, and that's the group of patients who will receive benefit from the drug without experiencing adverse effects. And so in practice, we see all of these patients, and there's a lot of reasons why that could be the case. There's all kinds of developmental reasons. Pharmacokinetics and pharmacodynamics definitely play a role. But one thing that we've learned over decades of research is that pharmacogenomics and genetic makeup can also determine which of these groups a single patient may fall into um, based upon known genetic variants, or maybe in some cases, there's many things we don't know about pharmacogenomics at this point, and we may not be able to provide the answers for why patients fall into which category. But we're really targeting that green group in the top right. And at the end of this, we want to be able to choose the medications and the doses that will achieve benefit, that won't achieve toxicity. Um, and I think that through pharmacogenomics, and we'll talk more about how, I think that we are potentially able to get to that point sometime in the future. This definitely isn't intended to be a pharmacokinetic, pharmacodynamic talk. I think there may be another one of those lectures available in the core competency series, but I do want to kind of just briefly highlight some of those variables that you should recognize affect therapeutic response in patients. That's really the pharmacokinetic and pharmacodynamic variables that I mentioned. Um, Things like absorption, we see that gastric enzymes can affect therapeutic response, or transport proteins, pulmonary function. In the distribution category, things like cardiac blood flow and distribution of water throughout the body can change therapeutic response. From a metabolism perspective, the dose certainly affects response. Protein binding and cytochrome P450 enzymes involved with metabolism can affect response. Things in the elimination category like GFR and renal blood flow or tubular secretion can all change the way that patients respond. Pharmacodynamic aspects of the drug, including target organ function and hormone or enzyme interactions, can change the way that patients respond. And so all of these things are kind of well known to affect patient response to medication. But the missing piece to the puzzle here is that pharmacogenomics itself, genetic variants, genetic makeup, can also affect therapeutic response, and in many ways will play a role in each of these buckets. So things like your cytochrome P450 function that falls in the yellow metabolism box can be very much affected by an individual's genetic makeup. So pharmacogenomics is really something that is involved in each of these, and it's the aspect of therapeutic response that we're going to really focus in on this presentation. To do that, let's define precision medicine. So according to the NIH, precision medicine is an approach to disease treatment and prevention that takes into account individual variability in genes, environment, and lifestyle. The big question is, how can we customize medication use to patient subgroups categorized by shared molecular and cellular biomarkers in order to improve outcomes? And I think the beginning part of this is what comes most into play in pharmacogenomics, and that's the variability in genes. So what we found is that, let's say there's this random genetic variable that 10% of the population has. Is there a different way that we should dose medications or a different medication that we can choose for that 10% of patients that would improve outcomes compared to the standard of therapy or compared to the medication or dose that the general population without that genetic variant would would best benefit from. We really want to be able to customize our drug selection, our dosing, things like frequency. We want to be able to customize those according to shared molecular and cellular biomarkers that we can identify through pharmacogenomic testing. A bit more specific, pharmacogenomics is the study of the relationship between variations in a large collection of genes and variability in a drug's disposition, response, or toxicity. So our goal in all of this is to understand how a patient's genetic variation contributes to variability in those boxes on the slide a few slides ago. Things like pharmacokinetics, pharmacodynamics, the toxicity of the drug. We know that pharmacogenomics might affect every drug differently, but ultimately we want to understand how a genetic variant contributes to changes in every single drug that we use, if there are changes that exist. We want to use genetic info to guide optimal drug selection and to guide dosing in order to maximize efficacy and minimize adverse effects. But how did we even get to this point? It wasn't that long ago, really, 70 years or so, at which time we didn't even know what the structure of DNA looked like. It was Rosalind Franklin's discoveries in the early 1950s that allowed us to develop the model of the structure of DNA, and it was advances throughout the 60s, 70s, and 80s in which we cracked the genetic code and developed techniques like DNA sequencing and polymerase chain reactions in order to be able to amplify genetic content to study it more thoroughly. Since that time, we now have over 100 drugs with pharmacogenomics related FDA labeling, and some of those are drugs that we use pretty often. You'll see a bunch of them listed here, and in the parentheses, we see the enzymes or the transporters or the proteins that are involved or that are included in the pharmacogenomic labeling from the FDA. Things like HLA and CYP2C19. Uh, all of them are now included in the labeling for over 100 drugs. Um, Roughly 65 or so of those medications with pharmacogenomic labeling are labeled for use in children as of 2016. But we have to be careful still because much of the labeling that's included is extrapolated or derived from adult data. So even though we have drugs that we use in kids for which labeling related to pharmacogenomics exists, we still have to often kind of use our prior knowledge of ontogeny and developmental changes to figure out how that labeling information and the data that we take from adult populations should be should be kind of modified to use in various pediatric populations and age groups, but I'll talk a little bit more as we go. In 2015, ASHP kind of weighed in for the first time on their official stance on pharmacogenomics, and you can see some of the highlights from that original statement here. Pharmacists have a fundamental responsibility to ensure that pharmacogenomic testing is performed when needed and that the results are used to optimize medication therapy. They said that all pharmacists should have a basic understanding of pharmacogenomics in order to provide appropriate recommendations. And they agreed that the emerging science should be spearheaded by pharmacists in order to promote safe, effective, and cost-efficient medication practices. And it's around this time when those of you who were still in pharmacy school would have started to see curriculum ramp up in the area of pharmacogenomics as some of the curricular standards started to change to include this advancing science. In addition to that, in JPPT, we also had an official position paper from the Pediatric Pharmacy Association. So at that time, PPAG endorsed the involvement of pediatric pharmacists in pharmacogenomic testing and endorsed the belief that pharmacists should be responsible for ordering, interpreting, and applying any pharmacogenomic test results. They encouraged all pediatric pharmacists to take responsibility for educating patients and their families about pharmacogenomics and agreed that the need for pediatric pharmacists trained in pharmacogenomics will become more and more important to the point that it will be essential. So that's kind of how we got to this um, core competency series. The fact that pharmacogenomics is included in this series is a major advancement, and we started to see that kind of take shape during the 2010s decade. So let's take a look now at some of the genomic terms that you'll hear throughout the remainder of the presentation, but also that will be common to pharmacogenomics. And you should recognize a lot of these terms from previous biology classes or genetics classes that you may have taken in the past. A genome is kind of the largest piece of the puzzle, and it's an organism's complete set of DNA. And I actually like to use the reference that was taught to me by a colleague that the genome is kind of comparable to a book, and each of these subsequent terms is comparable to a piece that makes up the book. So chromosome, that's a single piece of DNA containing many genes, regulatory elements, and nucleotide sequences, and that might be comparable to a chapter of the book. Then you have a gene, which is a region of DNA containing the code for a biological component, like a protein, and that would be a sentence, for example, that makes up a chapter that makes up the book. Whereas the nucleotide, that's really the building block of the DNA, the smallest piece of the puzzle, and that would be similar to an alphabet that makes up the letters within a sentence, within a chapter, within a book. And we have about 3 billion nucleotides in each one of us. And I just think that's a helpful analogy for figuring out the sequence of these terms and the definitions that they correspondingly have. There's a few more components or terms that I want you to be familiar with that we won't really get into much depth throughout this presentation, but they're important to know and you will see them elsewhere. I think that this image is very helpful. You can see on the left side of the image, there's all these areas where genetic variation can occur. Most of them occur within the gene structure in places like exons and introns and codons and promoter regions. And you can see various places that changes in protein products would occur or altered expression would occur. And these would then go on to affect genes in the form of regulatory proteins. So these could be drug metabolizing enzymes or drug transporters that correspondingly affect kinetics, or they could also be drug targets or interacting proteins that can have both therapeutic or toxic effects. Variants are defined by a difference in a DNA sequence compared with the reference sequence or the wild type sequence. That reference or wild type, those are going to be the sequences that occur most commonly in the population. So any difference compared to the general population would be considered a variant. And you'll see here in the bullets at the bottom of the slide that common variants defined as occurring in more than 1% of the population are called polymorphisms, whereas those variants that occur in less than 1% of the population are a bit more rare, and those would be called mutations. There's various types of mutations and polymorphisms that can occur. You might see one frequently appearing called a SNP, or a single nucleotide polymorphism. There can also be indels, which are insertion or deletion variants. I won't get into these today, but that's just here for your reference, and I think it's helpful to kind of understand the structure and the terms that are used throughout the pharmacogenomic literature. The last few important terms here are alleles. So this is one of two or more forms of DNA sequences at a specific position on a specific chromosome. You can have wild type or major alleles, or you could have a variant or a minor allele. And the groups of alleles that are found together are typically called haplotypes. Humans have two copies of every gene, and those are called, that just means that humans are a diploid species. It's helpful to see on the right, this is kind of just your typical view of how mom and dad's haplotypes can contribute to offspring haplotypes. Um, there's also genotypes and diplotypes, which are a combination of alleles or a combination of haplotypes that can be carried at a specific location of DNA. And all of these genetic structures then contribute to your phenotype. And a phenotype is the measurable characteristic that results from this combination of haplotypes, or this combination of alleles. So if a measurable characteristic like eye color or hair color would be your phenotype. And in the same way, a measurable characteristic like reduced metabolism would be your phenotype as it relates to drugs. So phenotypes can result from genetics, they can result from the environment, or a combination of the two. And in pharmacogenomics, the phenotypes that you'll frequently see are all related to metabolism or response. So you'll see ultra-rapid metabolizers or poor metabolizers, or some patients who are considered non-responders. And I think it's important to remember that phenotypes have varied a lot. It's kind of an evolving term with respect to the pharmacogenomics phenotypes that we see. So not every piece of literature that you look at from the last 20 years has a consistent use of the phrase, for example, ultra-rapid metabolizer. And that was a major downfall initially in the pharmacogenomic literature, but it's something that the organization CPIC and those involved in pharmacogenetics have more recently decided is an important area for standardization. So I'm going to talk a little bit about the definitions that are now considered to be standard that were agreed upon by pharmacogenomic groups. All right, so let's get into how genetic variation can contribute to clinical pharmacology. As pediatric pharmacists, you should recognize that every patient has inter-individual pharmacokinetic variability. That's especially important to pediatrics, and it's something that we factor into things like drug dosing every day. The extrinsic factors are thought about a little less often, but drug interactions are an important extrinsic factor that can affect pharmacokinetics. Smoking and diet and the environment are all factors that can contribute. The intrinsic factors are the ones that we are always thinking about. Pediatric pharmacists are very familiar with how age can affect pharmacokinetics. Race and gender can affect pharmacokinetics. So thinking about things like the Cockcroft and Galt equation from back in the day in pharmacy school, you'll recognize that there's parts of equations to calculate renal function that are dependent on age or on gender. Obviously, organ function plays a big role, so we correct for renal and hepatic impairment when we dose medications. Diseases can contribute to alteration in volume of distribution. Distribution itself can vary depending on a lot of factors. Pregnancy is a factor that very much affects pharmacokinetics and distribution specifically. And then genetics is the one piece that people don't always think about, but really that's why we're here today, is to learn about how pharmacogenomics can affect pharmacokinetics. Um, this is kind of a graphic that was adopted from this 2003 article that shows how all of these things are dependent on each other. Drug metabolizing enzymes, transporters, and drug targets or effector proteins are all things that can be affected by genetic variance. And if genetic variance occurs, it will most likely change in some way the way that a drug has effect. So it'll either change the efficacy of the medication or it will result in an increase or a decrease in the amount of adverse effects or the toxicity that is assumed by the patient who takes the drug. Um, Genetic variance can certainly be associated with alteration in metabolizing enzymes. And like we saw in the past couple slides, and we'll talk about in further detail, they can also affect other proteins involved in drug metabolism or function. So typically when we think about decreased function or a variation that causes decreased function, that usually results in decreased enzyme activity for whatever enzyme uh, is corresponding to the variant. It often results in decreased affinity between the enzyme or substrates and the target, and it can even result in an inactive or a non-functional enzyme. And so when we have these decreased function enzymes, we usually end up with decreased clearance, an increased area under the curve or increased drug exposure, and an increased half-life. On the flip side, we may see increased function proteins. And so those proteins or those enzymes will have increased activity. We can have increased affinity between enzymes and substrates. You can also have an increased quantity of enzymes. So having more of a certain enzyme will result in faster metabolism of a drug that requires that enzyme. This usually results in increased clearance, reduced exposure or reduced AUC, and reduced half-life of the medication. But with that, it's really important to remember which of the components of the medication in question are considered active. So if the ingested agent is active upon ingestion, it is considered to be an active parent drug. And if an active drug exhibits or is affected by a decreased function metabolism, then we're going to see the changes that are discussed here. But if the ingested medication is an inactive medication or a prodrug that is converted to an active form, then reducing the metabolism of the prodrug results in at least a reduced or it would result in a longer time to getting to the active metabolite. We'll talk about the example of codeine and how that's involved with metabolism to its active component of morphine. But there's a lot of medications that are considered to be prodrugs to keep in mind. Things like antiplatelet medications or PPIs are very much affected by changes in metabolizing enzymes. And if we don't know, or if we're not thinking about whether the ingredients that are ingested are active parent drugs or prodrugs, and whether metabolites are active or inactive, it can cause us to really misinterpret the results of some of these pharmacogenomic studies. If you know that a medication is metabolized by CYP2C19, but you mistakenly think that the ingested medication is active instead of the metabolite, and that isn't actually the case, that can really cause you to make some mistakes with regards to clinical implementation of some pharmacogenomics results. So just always keep in mind that you need to know whether the ingested medication is an active medication and whether metabolites are active or inactive when you're considering how to use these pharmacogenomic recommendations. So I mentioned a little bit earlier cytochrome P450 enzymes, and certainly these are the enzymes that we think about most often when we think about drug metabolism. It's not that these are the only enzymes that are involved in drug metabolism, but they're extremely well studied. They show up all over your pharmacy lectures, and they do play a major role in drug metabolism. Well, CYP450 enzymes can be extrahepatic. We care mostly about how they work within the liver. And in this lecture, we're going to cover CYP2D6, CYP2C19, and CYP2C9. But there's all kinds of additional cytochrome P450 enzymes that are involved. CYP3A4 is a big one. Um, CYP1A2 is one that often shows up in pharmacogenomic results. CYP3A5. So there's a lot of results that I'm not going to discuss here, but I'm picking out a couple of key CYP enzymes that are common to pharmacogenomic discussions and have good examples for pediatric use. And you can apply the concepts that we talk about today for these CYP enzymes to many of the other cytochrome P450 enzymes as well. Each person has at least 2 alleles for every CYP450 enzyme. Sometimes they might have 3 alleles. And when we look at the nomenclature for this, which can be seen in the bottom green square, um, we we annotate each of these alleles with a star and then a number. And when the way that you read this, you actually just say *1 if that's what you see here. So the example in the box, this patient would have CYP2D6 *1 *1, and that means that they have 2 wild-type alleles. The *1 allele is always the most commonly occurring allele in the general population. So if you have 2 *1 alleles, that means you've got 2 of the most common alleles, or 2 wild-type alleles. And the numbers are numbered sequentially in order of identification. Typically, we see lower numbers that have impact in pharmacogenomics, like *1, *2, *3, *4. But over time, we have developed some higher alleles that were discovered later on, but do have an important role in drug metabolism. And so we're going to review the certain types of alleles that are relevant for CYP2D6, CYP2C19, and CYP2C9, and kind of how those make an impact clinically, um, as well as really just how they affect an individual patient's metabolism. Before we get to that though, drug transporters and drug targets can also be affected, so it's not always the drug metabolizing enzymes that are impacted by pharmacogenomics. Transporters typically have 2 primary functions, one of 2 primary functions. They can either be responsible for cellular efflux, or they can be responsible for cellular uptake, and there's examples here for each of those. But those transporters, when they're modified, if that efflux is made more efficient or less efficient, and that uptake or reuptake is made more efficient or less efficient, those things can influence pharmacokinetics and or pharmacodynamics. And we can also see drug targets that are impacted by variations in genes. So these could be receptors, these could be ion channels, or just proteins involved in signal transduction. And the measurement of these is pretty variable and can be imprecise. So we don't often see, at this stage anyway, distinct phenotypes for drug targets. We'll talk about how you can be a rapid metabolizer or an ultra-rapid metabolizer, or a poor metabolizer, and those are all really referring to drug metabolizing enzymes, but variants can also affect drug targets. We just haven't really tied down standardized ways to measure those at this time, and those are more likely to influence pharmacodynamics rather than pharmacokinetics. All right, so the last slide before we get into the pharmacogenomics clinical interpretation and application is really, when should we be using pharmacogenomics to guide prescribing practices? I think there's probably 3 major categories in which pharmacogenomics should or could be utilized. Um, One of those would be in an instance where a drug has a narrow therapeutic index. So if we have a very narrow therapeutic index and there's a high risk for harm if you provide too much exposure to the medication, then this is an instance where we would want to use pharmacogenomics to ensure patient safety. There's times when drugs have unpredictable safety concerns that are not dose related, but we now know are impacted by a patient's genetic makeup. Good examples of those that you've probably seen in practice are that carbamazepine and its risk of causing Stevens-Johnson syndrome is genetic related. And so we can measure HLA genotypes and use those genotypes to predict the phenotype of the patient and predict subsequent risk of Stevens-Johnson syndrome. We could identify that a patient is at high risk or at least higher risk of developing Stevens-Johnson syndrome and avoid use of medications that cause it, like carbamazepine, or at least reserve those medications as a last line option. Same thing with rasburicase. If you've ever worked in an ICU or in hematology and oncology, you know that rasburicase can cause acute hemolytic anemia in some patients. And so we can do a quick, safe G6PD genotyping, and we can use that to predict the patient's risk of developing this potentially life-threatening acute hemolytic anemia. So those are two areas where safety can guide us to appropriate use of pharmacogenomics. There's also times when we need to really ensure that we're achieving maximum therapeutic effectiveness. And so those could be examples like cancer therapies and chemotherapy. Um, we could be referring to antiplatelet medications after a stent placement. So when you think back to a PCI and using antiplatelets for a certain period of time after that to prevent thrombosis related to the stent placement, it's really important that we don't have treatment failure. And there's some patients who may have less effectiveness or less therapeutic response to certain medications. And we can predict that by using pharmacogenomics to guide our selection of a medication or to guide our dosing of a medication if we know the patient's metabolism status. Finally, if safe or effective titration parameters are not easily determined, then we may see that we're having ineffectiveness or potentially side effects um, for unknown reasons. So we might be using what should be an effective dose and not seeing response, or we might be using what should be a safe dose and seeing side effects. And if we've gone through a couple of medications and failed them, or even a single medication, we can use a pharmacogenomic test to see if that provides us any more information about why the drug is ineffective. So thinking about many of our SSRIs, let's say we use one or two SSRIs that have the same metabolism pathway and they're not effective. We could do a pharmacogenomic test and either verify or rule out that metabolism variance in genetics is contributing to that lack of effectiveness. Same thing with cholesterol medications or pain medications. There's some patients who we would not expect to see an analgesic response for certain opioids, and that can be determined through evaluation of their pharmacogenomic status. So those are kind of three broad categories where I think it would make sense to use pharmacogenomics to guide prescribing. And there's really two methods, and it's somewhat controversial in the world of pharmacogenomics, and usually it's more controversial in the world of prescribing for people who don't have a pharmacogenomics background. There's kind of two broad strategies, and that's whether we use pharmacogenomics proactively and get a test before we select a medication and use the pharmacogenomics to pick a medication that we think is more likely to have effect or less likely to have safety issues. Or we can kind of use a reactive model um, and and check pharmacogenomic status after we have treatment failure or after we have a side effect. And one of the big ethical implications is if we can predict this, should we be requiring it for all patients? Um, or if we do require it, how can we prove that it's in the best interest of the patient, either economically or from an effectiveness perspective, to check that test before we start them on a medication. So there's two broad strategies. There's a lot of ethical dilemma that can be read about. There's all kinds of literature that describes these approaches. Um, and I don't think at this point we've really established that one approach is better than another. But I think you'll develop, if you work with pharmacogenomics often, you'll definitely develop some of your own thoughts and preferences surrounding the practice. And there's some hospitals who are really kind of leading our research efforts who do proactive, preemptive pharmacogenomic screening for a lot of medications. And at the very least, that helps inform the rest of our country about the really optimizing the use of pharmacogenomics to guide prescribing. So I'm thankful for those institutions. My own institution doesn't do a lot of preemptive pharmacogenomics, except in the event that, like we see here in bullets 1 and 2, safety or effectiveness is really going to be determined by a patient's pharmacogenomic status. All right, but you can look more into those. I'd love to have that discussion in greater depth. That kind of goes beyond uh, the scope of this intro presentation, but it's a pretty cool discussion to be a part of. So now let's really get into the pharmacogenomic resources that are available, especially for an entry-level prescriber, and how you would use them or could use them in practice. I'm going to kind of describe how I use them in my regular practice, and you can either adapt that to your own practice or just use this to familiarize yourself with these references and resources and to get to know them a little bit better. So the first one I want to talk about is PharmGKB, which stands for the Pharmacogenomics Knowledge Base. You can access this free resource at pharmgkb.org, and I'm going to go into a few examples of it in a little bit. But really, this website and this organization and knowledge base collects, curates, and disseminates knowledge about clinically actionable gene-drug associations or genotype-phenotype relationships. And what that really means is that they annotate all of the clinical guidelines from various international pharmacogenomic societies. That could be CPIC in the United States, and really that's a global organization. I'll talk about it a lot more throughout this presentation. There's a few other international societies, um, like the Dutch Pharmacogenetics Working Group, and they have really great clinical advice that can be referenced from PharmGKB. You'll get summaries and annotation of those guidelines at this website that's really pretty user-friendly once you get a feel for it. They also summarize and cite literature related to important pharmacogenomic genes or gene-drug pairs. So if you have something you're interested in, you can search using their search function, and you'll get a summary and the abstract even of the relevant articles that exist related to that pairing or related to that gene. They describe the impact between variants and drug effects, and they outline clinically important drug pathways. So like I said, they've got a great search function. You can search by CYP2C9. If you know a patient has a variant, you can search by escitalopram if you know you have a drug that you want to look more into. You can search by enzymes. You can search by a lot of different things. And the group that runs this has done a really good job of assigning the level of evidence according to the statistical significance or study size, or the fact that some results have been replicated in multiple studies in order to determine how likely or how reliable it is to use these summaries and annotations in your clinical practice. Next up is the Clinical Pharmacogenetic Implementation Consortium, or CPIC. Um, PharmGKB and the Pharmacogenomics Research Network kind of teamed up to establish CPIC in 2009. It's a very straightforward website to use. I'm going to provide some examples from CPIC here in the next few slides, but this is a consortium of experts that are really focused on the development of standardized, peer-reviewed, evidence-based guidelines for how to clinically implement pharmacogenomic testing. I like the way that they orient their discussion and their guidelines around gene-drug pairs. So you can go to their website and search by medication or search by gene and see which medications have associated guidelines or have labeling within their FDA approved labels, or if there's anything actionable related to a certain gene variant. And they break down a major barrier between obtaining results and understanding how to use them to optimize therapy. So in my practice, I really like to use the CPIC guidelines to help me make strong recommendations for how to adjust therapy or select a drug based on a patient's pharmacogenomic results. But I also often find myself playing the middleman role between a provider who got a pharmacogenomic test and needs assistance interpreting it. And CPIC, I think, is really my best go-to reference for helping providers interpret pharmacogenomic results and figuring out what aspects of those results are relevant to the patient's current medication list, to the patient's previous medication failures, or to the patient's future medication use. CPIC, like I said, has a lot of guidelines. At this time, over 60 medications have CPIC guidelines. You can see some examples of those here, ranging from NSAIDs in the top left to PPI dosing to selection and dosing of tricyclic antidepressants or SSRIs. Rasburicase has its own guideline. Ondansetron and tropisotron are anti-nausea meds that have their own guideline. Phenotyping can impact phenytoin dosing that has a guideline. COMT genotypes and opioid therapy. Really anything that has strong clinical evidence to guide use and selection and dosing adjustment at this time. Um, if there's enough evidence out there to really make a strong therapeutic recommendation that applies to the population, then CPIC likely has assessed it and may have a guideline or may have um, some type of recommendation about how to use that genotype status. Just recently, in the past few years, like I mentioned, CPIC has really pushed towards standardizing their allele functional status, as well as on the next slide, I'll show you standardization of the definitions for a patient's metabolic status. So first, they wanted to standardize how we define certain alleles and how allele function is described. So if you look at literature more uh, less recent, I'm sorry, than a couple of years, if you look at some of the older literature, you may see some inconsistency in the use of these terms. So just be careful when you're interpreting older studies. But now, if an allele is determined to have a function greater than normal function or increased function, then it will always use the definition an increased function allele. A normal function allele is the wild type allele that we mentioned occurs in the greatest portion of the population. That's a fully functional allele with normal function. Any allele with less than normal function or reduced function uses the term decreased function allele. We also have some non-functional alleles, and we'll use the term no function. We have some alleles for which there is not currently literature to describe, and those are called unknown function alleles. Or if the literature is conflicting or weak, we may rate an allele's functional status as uncertain. And so those terms moving forward should be consistent. You'll never see variation in the type of description of that allele functional status. The other important, probably more important update with regard to standardization was the metabolizer status. So we now see the final terms ultra rapid metabolizer, normal metabolizer, intermediate metabolizer or poor metabolizer. So looking over at the right column of this table, in the genetic definition, you'll see that if a patient has two alleles that each individually have increased function compared to the wild type allele, then that patient will have increased enzyme activity compared to rapid metabolizers, and we'll call them ultra-rapid metabolizers. If they have two normal function alleles, or maybe even one normal function allele and one decreased function allele, then they're probably going to have fully functional enzyme activity. And so that would be the middle row of normal metabolizer status. If we have two decreased function alleles, or maybe a normal function allele paired with a no function allele, that patient will have decreased enzyme activity, and they will be described as an intermediate metabolizer status. So that means they fall somewhere between normal metabolizers and poor metabolizers. And then lastly, if a patient is a poor metabolizer, that means they have combinations of two no function or decreased function alleles that leave them with significantly reduced enzyme activity, little to no enzyme activity in those cases. So then, once we know a patient's metabolizer status, we can look at whether the active drug, whether the ingested drug is active. We can look at whether metabolites are active, or maybe this is a prodrug, and determine what that change in metabolism resulting from enzyme activity is likely to contribute with respect to effectiveness and safety. Let's start with this common example of a metabolizing enzyme, CYP2D6. You should recognize that this is an important enzyme in drug metabolism. While it only makes up a small portion of the CYP proteins found in the liver, about 1/4 to 1/3 of drugs are metabolized in some part by CYP2D6, either as a major or minor pathway. And so some of the common examples that use this pathway include codeine, an important prodrug, SSRIs and TCA antidepressants are two categories that are often metabolized by CYP2D6. Antipsychotics as a class are often dependent on CYP2D6 metabolism. Beta blockers like propranolol or antiarrhythmic medications, all of these can be affected by changes or variants in normal CYP2D6 metabolism. So you can see in this chart that we have three types of alleles with respect to CYP2D6. We have some alleles that have normal function, some alleles that are known to have decreased function, and some alleles that have no function. And one of the concepts that's unique to only a couple of the metabolizing enzymes at the moment, but I think we'll likely see more and more of used across the pharmacogenomic board, is the concept of the activity value. So each of these alleles is assigned an activity value based upon the capacity of its function. So if a patient is CYP2D6 star 1 star 1, they have two normal function alleles, and their activity value will be the sum of those of 2. If a patient was CYP2D6 star 1 star 9, that patient would have one allele with an activity value of 1 and one allele with decreased function that has an activity value of 0.5. So their full activity value would be 1.5. You can see that star 10 has a little bit less activity than the other decreased function alleles, so it gets an activity value of 0.25. That's a more recent update to the activity score concept. And then once you have an activity score based on the sum of all of the function of all of the alleles that a patient has, that can be used to predict their likely phenotype. So you can see here that normal metabolizers make up about 70 to 90% of the population. That means they are going to have an activity value of 1 to 2. That means they could have two decreased function alleles that each contribute an activity value of 0.5. They could have two normal function alleles that each contribute an activity value of 1, we'll be able to use those activity values to determine that they are likely a normal metabolizer. Up to 20% of patients are considered to be ultra-rapid metabolizers, which in this case means they have an activity value of greater than 2, which means they would have to have an extra allele. They might have 3 normal function alleles or 2 normal function alleles and a decreased function allele. We know that up to 13% of patients are considered to be intermediate metabolizers. And so according to this score of an activity value of 0.5, they would need to have 1 decreased function allele paired with a no function allele. Or there's some patients who are poor metabolizers via CYP2D6, and they would have an activity score of 0, meaning they have no function allele. So how do we use that in practice? Well, codeine, like I mentioned, is an important prodrug that is metabolized to the active metabolite of morphine. CYP2D6 ultra-rapid metabolizers have CYP2D6 alleles that are more active. They have better efficiency in their metabolism. And so if patients have ultra-rapid metabolizer status, that means they rapidly metabolize the prodrug codeine into the active metabolite morphine. That likely means that patients with that status will have increased efficacy, will have more morphine in those patients, but they're also at increased risk of side effects. On the flip side, we saw in the last slide that up to 10% of patients have poor metabolizer status, which means they have 2 no-function alleles. And if they have 2 no-function alleles, it's going to be very difficult, or at least very slow, the process to get them from the codeine prodrug into the active metabolite morphine. So those patients are likely to see reduced analgesic benefit from the use of codeine. They are very slowly going to metabolize from the prodrug to the active drug due to their no function metabolizer status. They are poor metabolizers. So what we've seen a lot, codeine is certainly a medication that can be used effectively. It can be used with great analgesic benefit in the right patients. But morphine is also an active metabolite with a lot of risk. The potential for respiratory depression can be pretty great, and that contributes in large part to the contraindication and the boxed warning that exists on codeine to say in the United States, codeine is contraindicated in patients less than 12 years. And additionally, there's a relative contraindication in older pediatric patients less than 18 years to using codeine for things like tonsillectomies or tooth extractions. Really, there's just a risk without knowing the patient's pharmacogenomic status of the patient being an ultra-rapid metabolizer and having an increased risk of side effects, or being a poor metabolizer and having reduced pain benefit. And really, at that point, if we're not getting the analgesic effect, then it's not a medication we want to be using for surgical treatment of pain. It's also important to note that allele frequency often varies by population. So CYP2D6 is a good example of this. And all of this information can be found in the CPIC guidelines. But poor metabolizer status occurs 5 to 10 times more often in Caucasian patients than it does in Asian patients. That's just one example, but all of our phenotypes have some, well, most of our phenotypes have some variation in frequency that is associated with kind of race and ethnicity. So again, this slide is just really going to drive home the point that we need to know whether a medication is a prodrug or an active metabolite, and we need to really consider those statuses as we think about how to adjust the medication or select a medication as a result of pharmacogenomics. CYP2C19 is my next example. This enzyme accounts for 10% of all of the drug metabolism, all of the drugs on the market. 10% of them use CYP2C19. They could include clopidogrel, SSRIs and TCAs again, voriconazole, or PPIs. Again, we see that star 1 is the normal function wild type allele. We have some no function alleles, and we have one increased function allele in this scenario, star 17. In this case, the phenotypes for CYP2C19 are again ultra rapid, rapid, normal, intermediate, and poor. And there's a wide-ranging occurrence of all of the rapid, normal, and intermediate metabolizer statuses. So a normal metabolizer will carry two star 1 alleles, whereas a rapid metabolizer would carry a normal function allele and that increased star 17 function allele. An ultra-rapid metabolizer, which makes up 2 to 5% of the patient population, those patients would carry two increased function star 17 alleles. So how do we use that? One really great clinical example of the CYP2C19 impact on efficacy is that patients with intermediate or poor metabolizer status, meaning those patients who have reduced metabolism or reduced function, have higher H. pylori cure rates when they're using a PPI like omeprazole. And the reason for that is that these patients with reduced metabolism, intermediate and poor metabolizers, likely have increased omeprazole plasma exposure compared to normal metabolizers. So this is great. That means that there's a clinical benefit that patients with genotypes predictive of higher plasma exposure likely have more of a benefit in scenarios where they need more exposure to the medication. But it's also important to think about how that plays an impact on risk to the patient. So we think about long-term PPI use, for example. Many of our pediatric patients for reflux take PPIs, in my opinion, for far longer than they should be. But we can kind of use that to predict risk as well. Patients with reduced metabolism of those PPIs will likely have increased plasma exposure over their lifetime, and so you could consider a dose reduction to minimize the risk of toxicity while also potentially achieving the same therapeutic effectiveness. Similarly, in these patients with normal metabolism who maybe have an H. pylori infection, we know that they're going to have reduced exposure compared to these intermediate and poor metabolizers who have great cure rates. And so the guidelines may actually recommend increasing the initial starting dose for a PPI in those patients who we know are going to have reduced plasma exposure. My last important CYP2C19 or CYP450 enzyme to discuss in this lecture before I get into how to use CPIC and other resources is the CYP2C19 metabolizing enzyme. And so this is really abundantly expressed in the liver, and it's involved in about 15 to 20% of medication metabolism. Some of the common drugs that use this pathway are phenytoin and NSAIDs and warfarin. And you can see here that CYP2C9 is another one that uses the activity value concept. There aren't as many phenotypes or alleles that are involved in this one to keep straight, but like always, the star 1 allele is going to be the wild type allele. It's considered to be normal function. We don't see any increased function alleles for CYP2C9, but we do see some decreased function alleles, and those would have an activity value that is a little bit reduced. And then we have some no function alleles that would have an activity value of 0. So you take up the activity value associated with each of the patient's alleles, find the sum of that, And the sum of that in the right-hand column will help you predict the likely phenotype for CYP2C9. And the patient will either be a normal metabolizer or an intermediate metabolizer or a poor metabolizer. There's a couple of clinical examples of this. Patients with reduced metabolism, intermediate and poor metabolizers in this case, have increased phenytoin exposure, and therefore they have an increased risk for side effects. That also means that they likely have decreased phenytoin dose requirements. And so maybe in these patients, we would be able, if we knew empirically what their CYP2C9 status was, we could predict decreased phenytoin dose requirements and adjust accordingly. Kind of similarly to that, we know that intermediate and poor metabolizers have reduced ibuprofen metabolism. They also, as a result, have increased ibuprofen exposure and increased risk for side effects. So in those patients, we think that they're going to have increased side effects. Maybe we can use reduced ibuprofen doses or minimize the total exposure because we know they're a greater risk for side effects. Or in the case of NSAIDs, we could choose an NSAID that is not metabolized by CYP2C9, like naproxen. And those are really going to be laid out for us, that decision-making pathway in the CPIC guidelines. So I'm going to show you briefly how I would use the CPIC guidelines in a number of scenarios. When you go to cpicpgx.org, you'll be greeted with a nice introductory site. I always like to use the genes drugs section of the website. I'm not savvy enough with recording a lecture to visit this website for you, but if you click on it, you'll see that there are over 100 gene drug pairs, and this list can be sorted by enzyme. In this case, I sorted by CYP2C9. You can also sort your columns alphabetically by drug and see all of the drugs that have enough evidence for CPIC to weigh in on pharmacogenomic status. You can see the level of evidence here. In the case of fluvastatin, there's a 1A level of evidence. In the case of ibuprofen, there's a 1A level of evidence. And all of these three examples have guidelines associated with use. So if you click on that blue hyperlink that says guideline, it will take you to a related CYP2C9 guideline for that medication that helps you make decisions about selection of a drug or dosing of a drug based on the patient's known genotype or even their known phenotype. There's also some medications in CPIC that will not have guidelines, but they might have actionable evidence or they might have labeling in the FDA approved label, and that will be shown for you in this table. So I wanted to use the example of ibuprofen, I believe. So when you click on that blue guideline hyperlink next to ibuprofen, it'll take you to the guideline for all NSAIDs. This is the CPIC guideline for CYP2C9 and nonsteroidal anti-inflammatory drugs. And when you scroll down to table 2, you'll see, for example, that if you know the patient has a normal metabolizer phenotype based on their alleles, that means they will have expected normal metabolism, and you can initiate therapy with the recommended starting dose. What if the patient doesn't have normal metabolism, though? You can see in this same table, based on the patient's activity score, you can figure out what their metabolizer status is. So if the patient has an activity score of 1 in this first row, you can see that the clinical implication of that is that they will likely have moderately reduced metabolism. They may have increased probability of toxicities because they're metabolizing the NSAID slower than the general population. And so in this case, they recommend always starting with the lowest recommended starting dose. So you may have some medications with a range for their initial dosing. They say if your activity score is 1, you should not be picking the high end of that range. You should be starting at the lowest recommended starting dose. Similarly, if the patient has 2 no function alleles, they would have the poor metabolizer status. And in the bottom row, They provide the recommendation right here for you that you should initiate therapy with 25 to 50% of the lowest recommended starting dose. So because of the probability the increased probability of side effects and potentially the increased severity of toxicities, they say you should start at 1/4 to 1/2 of the recommended starting dose, and that your maximum dose should also be 25 to 50% of the usual maximum. Once, I'm sorry, in the bottom part here, it says that you should not begin titrating doses upward until steady state is reached based on the potential severity of toxicities. And they also outline some alternative therapies in the NSAID class that are not metabolized primarily by CYP2C9. So they say rather than using ibuprofen, use aspirin, ketorolac, naproxen, or sulindac, and you will not see the risk associated with their CYP2C9 poor metabolizer status. So let's say you get these pharmacogenomic results, and this is kind of what my own pharmacogenomic summary notes would look like. In this case, you have a patient who has reduced CYP2C9 metabolism. So based on their star 1, star 2 alleles, we know that star 1 from a few slides back will contribute an activity score of 1, and star 2 is a reduced function allele, so it will contribute an activity score of 0.5. And with an activity score of 1.5 between those two alleles, we know from the guidelines that patients will likely have mildly reduced metabolism, and our guidelines from CPIC suggest that you can initiate therapy with the recommended starting dose and just use the lowest effective dosage for the shortest duration based upon the patient's mildly reduced metabolism. But what about an example in which there are no guidelines? This is where we're going to kind of get into some additional resources, and I'm going to teach you how I would use PharmGKB. Venlafaxine is an SNRI that is reliant a bit on CYP2D6 for metabolism. And you'll see right in the package labeling that there's some statements about pharmacogenomics and venlafaxine available for all prescribers. And it says that in vitro studies indicate that the formation of the active metabolite is catalyzed by CYP2D6, and that this has been confirmed in a clinical study showing that poor metabolizers have increased levels of venlafaxine and reduced levels of an active metabolite. But then when I go to CPIC, this is the row of CPIC that I see. And under that guideline row, there is no hyperlink, meaning there is no guideline for how to manage venlafaxine in a patient with a CYP2D6 variant. But it does say that the FDA label describes this as an actionable pharmacogenomic status and that the level of evidence of 1A is pretty good. So that would tip me off that although there isn't enough information for a guideline in this case, there is some information out there that I can use to use my own clinical judgment and make a decision about. So this is where I would use PharmGKB. When you get to PharmGKB, I mentioned earlier that it's a very searchable site. You can search by drugs or by enzymes. You can search by genes specifically. And when I search by venlafaxine, I can see that there are 34 clinical annotations, kind of in the middle of your screen. I can't use my laser pointer right now, but there's 34 clinical annotations. And if I click on clinical annotations in this PharmGKB site, it's going to take me to a summary list of all of the um, enzymes, the gene variants that are involved, and whether the evidence shows that the variant affects efficacy or safety or both. So let's say I click on clinical annotations for venlafaxine, and it takes me to this view. Sorted by level of evidence, I can see at the top that the level 1A aspect of this PharmGKB clinical annotation involves the star 1 variant, the star 3 variant, the star 4 variant, the star 5 variant. All of these variants are here described, and they show me that this evidence relates to toxicity. I can also see some reduced levels of evidence, level 3 and level 4, that are involving other variants, like CYP2C19 or a specific gene. You can use those and by all means read about them, but the evidence is either going to be mixed or it's going to be a weaker study. I really want to look at this level 1A evidence about venlafaxine and toxicity. And so if you click on the blue button that says details, you'll actually get a summary of the variants that are involved and what the studies out there have found. So if I had a patient with a star 4 allele, I would be able to read that in the case of CYP2D6, the star 4 allele has been assigned as a no function allele by CPIC, and that in clinical studies, patients carrying the star 4 allele in combination with any other allele are more likely to develop side effects when treated with venlafaxine, um, compared to those patients that have a normal metabolizer phenotype. But they also state that there is some conflicting evidence and that other genetic and clinical factors may also contribute. So maybe this conflicting evidence or these other contributing factors are the reason why CPIC has been unable to weigh in with a guideline for CYP2D6 and venlafaxine use. But it's a really great summary of what has been found, and it also provides in the same site the study that this information came from. So this one came from a 2006 article about CYP2D6 polymorphisms and the clinical effects of venlafaxine. And they actually found in this study that the patients with these no function alleles experienced increased risk of side effects when treated with venlafaxine for depressive disorder compared to patients with CYP2D6 star 1 star 1. So we have these patients with no function alleles compared to a normal metabolizer. They had increased risk of side effects, and it tells you here even so far as the statistical assessment. In this case, the p-value was less than 0.005 for this risk of side effects in these patients. You can also use Lexicomp, and I know that this is a favorite drug resource for me and many other pediatric pharmacists. When you go to the monograph for venlafaxine or any other drug for which pharmacogenomic data exists, or maybe there's controversy, you'll often find a pharmacogenomics subheader in the outline for venlafaxine, or you could do a control F and search for pharmacogenomics. And when you click on that section, it'll take you to a section of the monograph that describes that gene testing may be considered, and it includes a hyperlink there for the CYP2D6 and venlafaxine summary of information. When you click on that hyperlink, you actually get a pretty hearty discussion about the data that exists, and I'll provide that example for you here. When you click on that hyperlink, you get some discussion about how CYP2D6 converts venlafaxine to an active metabolite, ODV, and how those together contribute to therapeutic effect. You get information about how Cmax can be affected by various pharmacogenomic metabolizer statuses. There's some information about using activity scores and how that can be associated with significant changes in exposure. There's good discussion about how studies are conflicting relating to the relationship between CYP2D6 and venlafaxine. You can even get case study information, such as this one case study where a patient experienced cardiac adverse effects as a poor metabolizer. So there's a lot of information here. You'll get additional references from this discussion. And I think it's really important to just know that this exists and be able to get to this information, read it and digest it for yourself, and use your clinical judgment to determine if you need to make any recommendations on drug selection or how to select an appropriate dose for your patients in those scenarios where there really isn't sufficient data for CPIC to say universally in a patient with this metabolizer status, you should reduce the dose. You might personally be able to say, for this patient in front of me, based on everything I know about them, including their pharmacogenomic status, I'm going to encourage the provider to start with a lower dose or to select a different medication based upon the patient's known pharmacogenomic status, their known genotype, or their known phenotype. So this is just one of the many resources that can be used as kind of a piece of the puzzle. I wouldn't make any recommendation on the basis of any specific single piece of pharmacogenomic literature alone, but you can kind of compile all of the available evidence and use it to make your recommendations, just like you would if you knew a patient's creatinine, um, and you wanted to make a decision about how to change their dosing as a result of that. So that was the last of my examples for how to navigate these resources. These are just some of the pharmacogenomic resources that are available. And at the end of this slide, I'm going to provide, or at the end of this presentation, I'm going to provide a link um, to an NIH website that compiles even more pharmaceutical resources related to pharmacogenomics. But I did want to highlight a few of the challenges and opportunities that currently face us as pharmacists and as pharmacogenomic resources and researchers. So first of all, one of the biggest challenges is related to implementation, and that's that there needs to be a high level of clinical decision support in order to make sure that the people who are acquiring pharmacogenomic data know how to use it and use it effectively. St. Jude does a really good job. I provided this link here to some of their implementation resources, um, but they've kind of highlighted many of the challenges and opportunities that exist. The big one related to clinical decision support is that most EHRs do not currently have the ability to appropriately handle genomic information, and there's kind of a lack of standards for the data, scalability, and storage of such info. So I know in my hospital right now, um, we don't have discrete areas of the results review within our electronic health record to show us that, for example, the patient is a poor metabolizer, or to show us that they're a star 2, star 3 genotype. In order for me to get to that information, I currently have to go into the media tab, look at a scanned copy of the patient's pharmacogenomic results, or in some cases, if myself or another pharmacist has already summarized those results, I might be able to search the patient's chart to get to their pharmacogenomic assessment summary. But I would love to have the ability, like some other EHRs have implemented, to go to my results tab and look at um, a patient's allele right next to where I look at their sodium level from today's blood draw. And I also want the electronic health record to have built-in clinical decision support that guides me into, for example, saying that carbamazepine should not be used in this patient because of their HLA status and their risk for Stevens-Johnson syndrome. Someday, I think that our EHR will have built-in clinical decision support like this, but at the moment, we are not yet there at most hospitals. From an understanding perspective, many providers may not understand the benefits of using pharmacogenomics, or maybe they don't understand the risks of not using pharmacogenomics for particular medications, or in some cases they don't know how to interpret the findings, and so they avoid the use of those medications entirely despite potential benefit. In order to either avoid testing, they may just stop using the drug in question. So that's something we definitely want to try to work through in the future through education. There also may be reluctance that if they interpret things incorrectly, There may be additional liability for incorrect decisions or the use of less common alternatives that are suggested based on a patient's pharmacogenomic results will introduce new risks based upon a patient's unfamiliarity or a provider's unfamiliarity with a medication. So that reluctance is definitely well founded, but I think it's something that we can work through as pharmacists involved in education. There's also ethical dilemmas, which are well described elsewhere. I'm not going to focus on those in this presentation, but specifically in pediatrics, there's some dilemmas related to at what age we should be getting pharmacogenomic results, um, whether it's important for patients to provide consent or in some cases assent related to the acquisition of pharmacogenomic results, because we could learn things from pharmacogenomic results that we didn't previously know, or that may be undesirable knowledge. For instance, that could impact mental health on the basis that you learn something about a future risk that isn't entirely relevant at this time. But there are some institutions like St. Jude who have PG4 Kids, which is an effort to preemptively implement pharmacogenomic testing for all patients and for all gene-drug pairs. But an important effort to note that you shouldn't put results in the EHR without using clinical decision support to actively guide prescribing. And so I think St. Jude is really driving a lot of the discussions that we're having. I think that what they're doing is really remarkable from a pharmacogenomics perspective, and I'm jealous of the pharmacists that get to be involved with that. The last kind of challenge that comes up often is whether these findings and these changes are truly going to have a clinical impact and what the economic impact might be. Some people would argue that healthcare dollars are better spent elsewhere, but as these pharmacogenomic tests get less and less expensive over time, I think that argument is kind of going by the wayside. But we do lack randomized prospective trials that compare pharmacogenomic-based prescribing to conventional prescribing. And so I think that that's something that has been recognized and will hopefully be addressed in the near future. But we routinely use imperfect evidence in other areas, and we often extrapolate things from adult literature or from literature in other populations than our own patient population to guide our decisions. We do that every day to kind of guide um, us, to guide care as pharmacists when there's a gap between solid evidence and an unstudied clinical scenario, like liver or renal dysfunction for some drugs. Almost everything we do in pediatrics operates in a gray area, so there's really nothing different about using pharmacogenomics. It provides us with additional information that can be used as one piece of all of the available information to guide our decision making. I think that's what's important about pharmacogenomics and what I hope we'll continue to see advance in the near future. And so that leads me, I think, into our self-assessment questions. Thank you for sticking this out. It's a fun topic for me to discuss. Hopefully you feel like you learned a little bit more about pharmacogenomics and pharmacogenomic resources through it. But my first self-assessment question for you is, how can pharmacists best utilize previously obtained pharmacogenomic information when selecting new treatment for a patient's specific disease state? Should the pharmacist compare the patient's results to that of the parent's genetic information? And if those results are similar, select a medication that previously worked well for the patient's mother? Should the pharmacist alternatively choose a one-size-fits-all approach and utilize the most common medication and most common dosing to treat the disease state? Should they review the results alongside the current consensus guidelines to aid in the optimal drug selection and initial dosing if appropriate? Or should the pharmacist avoid using the genetic information because there is little definitive evidence to support clinical use at this time. Hopefully, upon reading those options, you determined that option C, review the results alongside current guidelines to aid in the optimal drug selection and initial dosing, is really the best way to use pharmacogenomic information you already have when you're selecting a new treatment for a patient's disease state. Question number 2. Which medication or medication class has an available CPIC guideline that can be utilized to guide practice? Is it the proton pump inhibitor class, the NSAID class, phenytoin, or all of the above? And through our patient case examples today, you should recognize that all of these drugs are impacted by pharmacogenomic variants, and all of them currently have CPIC guidelines to guide decision making. That brings us to question 3. Which of the following resources can be used to quickly find a summary of available pharmacogenomic annotations if there are no existing CPIC guidelines for a desired drug or gene variant? Is it PubMed, PharmGKB, Micromedics, or UpToDate? Well, all these resources would likely contain some information about pharmacogenomics. PharmGKB is really the one that is going to provide a summary of all of the available evidence. So if there's no CPIC guidelines, I like to go to PharmGKB next. It's very searchable. You can figure out the quality of the evidence based on the PharmGKB assessment of evidence. You can get a summary and a direct link to the PubMed resources that are most relevant, so you don't have to search that yourself. And really, you can use the information on PharmGKB to determine if, even though there's not enough information for a CPIC guideline, perhaps there's enough information for you to use for the patient before you. For self-assessment question number 4, you receive pharmacogenomic results for a patient named TJ who is shown to be an intermediate metabolizer via CYP2D6. So based on table 2, this is dosing recommendations for tricyclic antidepressants. What is the recommendation for therapy related to TCAs for TJ? Should you avoid the use of TCAs? Consider a 25% reduction in the recommended starting dose? Consider a 50% reduction in the recommended starting dose? Or just use TCAs however you want because no adjustment for TCA use is warranted. Hopefully you picked out from the vignette that TJ is an intermediate metabolizer. So you can go to the intermediate metabolizer row of table 2, and you'll see that the therapeutic recommendation from CPIC is to consider a 25% reduction of the recommended starting dose, or answer B. Answer C, the 50% reduction, would apply to the bottom row of this, poor metabolizers. In poor metabolizers, it's recommended to avoid TCAs, but if a TCA is warranted, you should use a 50% reduction of the recommended starting dose. But in TJ's case, he's an intermediate metabolizer, and so a 25% reduction in starting dose would be appropriate. For question 5, patient TJ has recently now been experiencing back pain, and the doctor desires to start TJ on naproxen. After the recent recommendation you made for his TCA, the doctor asks you if you have any recommendations for naproxen, and you notice that TJ is also a CYP2C9 poor metabolizer. So you look into the guidelines for CYP2C9 and NSAIDs. Here on the screen you see table 2, which is titled Therapeutic Recommendations for Celecoxib, Florbuprofen, Lornoxicam, and Ibuprofen based on CYP2C9 phenotype. What will you tell the doctor about naproxen use for TJ? Should you increase the naproxen starting dose by 25%? Initiate therapy with 25 to 50% of the lowest recommended starting dose. Is naproxen not primarily metabolized by CYP2C9 and therefore no adjustment is needed? Or should you switch to a different NSAID? And this one's actually meant to trick you. It's important to read the drugs that are involved in the tables for each CPIC guideline. In this case, naproxen was not one of the Table 2 medications. And in the last column here on the right, you can see that in patients with CYP2C9 poor metabolizer status, CPIC actually recommends the use of a medication not primarily metabolized by CYP2C9, including aspirin, ketorolac, or naproxen. So since this provider wants to use naproxen, the poor metabolizer status of TJ won't make a difference, and you can choose answer C, no adjustment in therapy is needed. Hopefully all of those self-assessment questions make sense to you. Um, Really, I want you guys to just be familiar with pharmacogenomics as a topic and to recognize the resources that are available to you as a provider who might weigh in on pharmacogenomic adjustments. And I think it's important to know that precision medicine really is coming. It's going to be the future. We're learning more and more every day about enzymes and transporters and really every step of the process of drug metabolism and pharmacodynamic response. And with each passing day and with each new study, we're better able to customize medication use to patient subgroups. So we're going to take patient subgroups, define them by their molecular and their cellular biomarkers, and be able to customize medication use in order to improve outcomes. Until the day comes that widespread availability exists, though, education and implementation will be key, and it's up to us as pharmacists to use resources like CPIC and PharmGKB to find the evidence necessary to guide our own personal decision making and to guide our own education of our colleagues across all disciplines. Pharmacogenomic testing should be considered for medications in which safety or effectiveness can be shaped by using the patient-specific information available. Um, I don't think it's necessary for all medications at this time, but by all means, if safety or effectiveness can be impacted and is known to be impacted by common pharmacogenomic variants, then genomics can be a valuable piece of the collective evidence used to guide both drug selection and dosing. So with that, I want to thank you again for joining me for the talk today. Like I mentioned, genome.gov has some really good pharmacogenomic resources. The link here on this slide takes you to the Genetics Genomics Competency Center, and they have a lot of competency sources that are available. This is an online repository of peer-reviewed collections of educational materials. You can filter it by topic so that you really get the best pharmacogenomic resources. And it also includes access to both free and paid access resources. So you can determine which of those are most appropriate based on your needs. Otherwise, these next two slides provide a list of some of the references that were used throughout. Many of them were the CPIC guidelines that I used to guide or to provide some clinical examples for CYP2D6, CYP2C9, and CYP2C19. And with that, that's the end of the presentation. So thank you for joining me. I appreciate the opportunity to have maybe introduced you to pharmacogenomics. I think that you should definitely look more into it, get involved in the discussions, get involved in the clinical implementation, and I hope that we can talk about it sometime again in the future. Thank you.